everyone, my name is Jacqueline, and today is 7/15/24, and I'm going to be doing my Unit 4 case connections, and I chose to conquer case 1 and case number 4. First, for case number 1, it states a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. A full blood work was ordered for this female, and this is the data that it presented. The initial blood ammonia level was 314 and then rose to 600. And analysis showed urine orotic levels were markedly elevated at 473, and the plasma citrulline level was normal at 10. And so the first question asked me to discuss the normal mechanisms of ammonia transfer in the body that should be occurring, including glutamate dehydrogenase, glutaminase, and glutamine synthetase, and to discuss the role of transamination. So ammonia is a byproduct of amino acid metabolism, and if present in high levels, it is toxic. The body has several mechanisms to effectively transfer and eliminate ammonia so it does not reach toxic levels. Glutamate dehydrogenase is an enzyme that catalyzes the oxidative deamination of glutamate into alpha-ketoglutarate, the ammonia within the liver. This enzyme has a crucial role to play in the catabolism of amino acids. Glutaminase is an enzyme that can convert glutamine to glutamate and free ammonia. This process occurs in the kidneys and liver. The ammonia that is released is either excreted in the urine or converted to urea. Further, the enzyme glutamine synthetase is able to synthesize glutamine from the glutamate and ammonia. Its purpose is a detoxification strategy within the peripheral tissues. It does this by incorporation of free ammonia into a form that is not harmful to the body. The second question asks, how is nitrogen transport connected to the gluconeogenesis in the fasted state? During the fasted state, amino acids are catabolized for the process of gluconeogenesis. This process involves amino acids being converted to glucose. The byproduct of amino acid catabolism, which is nitrogen, is required to be transferred into the liver for the synthesis of urea. Alanine and glutamine are the primary carriers of nitrogen. Through transamination, alanine is formed in the muscle. It has the ability to transport the nitrogen to the liver, where it can be converted to pyruvate and then eventually glucose. Question 3 asks, in this individual where orotic acid levels are elevated, what urea cycle enzyme is most likely deficient and what urea cycle enzyme is least likely to be impaired? The elevated orotic acid levels associated with normal plasma citrulline levels suggest a deficiency in the enzyme ornithine transcarbamylase, known as OTC. OTC deficiency is a very common disorder of the urea cycle. The deficiency leads to the accumulation of carbamyl phosphate. Carbamyl phosphate is redirected to the synthesis of orotic acid, thus elevating the levels. Arginosuccinate synthetase would be the enzyme that is least likely impaired because the citrulline levels remain normal in this patient. Question 4 asks, which amino acid, if any, becomes essential as a result of this deficiency? In this case, the patient does have an OTC deficiency. The amino acid arginine will become essential. In the urea cycle, arginine is normally synthesized and required for protein synthesis and plays a role as a precursor for nitric oxide and varying metabolic processes. Moving on to case number 4, my second case. This case presents a 50-year-old woman at the emergency department with progressive fatigue and weakness for the past 6 months. She is short of breath after walking several blocks. On review of the system, she mentions mild diarrhea. She has noted intermittent numbness and tingling of her lower extremities and a loss of balance while walking. She denies other neurologic or cardiac symptoms and has no history of black or bloody stools or other blood loss. On physical examination, she is tachycardic to 110 beats per minute. Other vital signs are within normal limits. The head and neck examination is notable for pale conjunctivitis and a beefy red tongue with loss of papillae. Cardiac examination shows a rapid, regular rhythm with a grade 2/6 systolic murmur at the left sternal border. Neurologic examination reveals decreased sensation to light touch and vibration in the lower extremities. No depression noted. The hematology consultant on call is asked to see the patient because of low hematocrit level. Megaloblastic anemia is suspected. The first question asks, which of the following vitamin deficiencies the probable cause of this presentation? Discuss each option and note which deficiency is most likely, whether it's iron, B6, or B12. Okay. And so, the clinical presentation of a 50-year-old woman who has many symptoms, including the ones just listed, is suggestive of a vitamin B12 deficiency. A iron deficiency is not likely because it would lead to microtic anemia rather than megaloblastic anemia. It does not commonly cause neurological symptoms such as numbness, tingling, or balance incompetence. Vitamin B6 deficiency is also unlikely in this patient. Vitamin B6 deficiency does not cause megaloblastic anemia and is not commonly associated with neurological symptoms. A sign of vitamin 6 deficiency would be microtic anemia, dermatitis, depression, and irritability. Vitamin B12 deficiency is most likely the diagnosis for this patient. The patient's symptoms are strongly indicative of a lack of vitamin B12. The megaloblastic anemia and neurological abnormalities would also be explained with this diagnosis. The second question asks me to discuss this vitamin deficiency, how it impairs purine and pyrimidine metabolism. Vitamin B12 deficiency impairs DNA synthesis, which requires the nucleotides of purines and pyrimidines. B12 acts as a cofactor for methionine synthase, which is an enzyme that converts homocysteine to methionine, thus facilitating the regeneration of tetrahydrofolate, also known as THF. THF is a key factor in the synthesis of thymidine, a pyrimidine, and purine nucleotides. In the case of a B12 deficiency, folate is trapped in the form of methyl THF. This leads to ineffective DNA synthesis. This ultimately results in the megaloblastic anemia that is present in patients with a B12 deficiency. Lastly, the third question asked me to list potential laboratory tests and findings that would assist in your differential diagnosis. So there are many tests that can be performed in order to assist in the diagnosis of a B12 deficiency. A complete blood count will show macrocytic anemia with an increased mean corpuscular volume. Serum vitamin 12 levels will be low in the case of a vitamin B12 deficiency. Serum folate levels can help distinguish between folate and B12 deficiency. Methylmalonic acid and homocysteine levels will be elevated, and reticulocyte count will typically be low in a panel. Overall, there are many tests that can help confirm B12 deficiency diagnosis and rule out other causes that may cause a megaloblastic anemia. And these are all the references I use to help support my arguments, and thank you so much for watching.